what should be the approach and how to approach the Simman and all the basic things about the Simman. So specifically, I'm going to discuss about acute limb ischemia, Simman, which is common in exam as well. So there are few things which you need to keep in your mind when you go in and you find out that this is the acute limb ischemia, and we will discuss that in a while. And if anyone has question, they can ask anytime, or if you want to write it down and you can ask it in the end, it's totally up to you. So what Dr. Kurat has told you, let me just quickly recap it, that you all know at this point, you all know that when you go into the room, you will find one Simman in the room, and you will find an examiner in the room. As you know that what is Simman? Simman is a uh, simulated mannequin which can talk and which can gesture, which can blink his or her eyelids. So yes, when you are outside, so definitely you will be having a question. And if we specifically talk about the acute limb ischemia segment, so most probably you will be in A&E, and patient will be middle-aged or old-age patient. And it will be written that he is presented in the A&E with either pain in the leg or with a complaint. And the rest of the stage scenario is that you are FI to please talk to the patient and assess or address the patient or manage the patient. Okay, so you will go into the room. First, let's discuss this. Should steps which you should be followed in all segments. So when you go into the room, first thing is you have to introduce yourself and you need to confirm the identity of the patient, then reassure the patient, and ABCDE approach. I will discuss this one by one. First, you go into the room, you will ask the Simman, or I can use the word with Simman or patient. So don't confuse if I say patient. So assume this is a Simman. We are talking about Simman class. So when you go into the room, you will say, "Hello, my name is Dr. Blah blah blah. How can I help you?" Or whatever your opening statement you have uh, practiced. It's totally up to you. You can use any one of them. um, okay, the patient will say, "Doctor, either he will be complaining of pain or he will be it's acute limb ischemia, so definitely he will be complaining of pain in his leg." So you should be asking which leg, and do the scores, all those things. But before that, you need to confirm the identity of the patient as well, even if he is screaming. So he, like, you went into the room and Simman shouted, "Doctor, doctor, I have a severe pain in my leg." So you need to confirm the identity, but after a few more sentences. So patient is not in a comfortable state. So you should comfort the patient first. So you will ask which leg, he will tell you since when, or your third question will be then, are you comfortable to talk? Either he will say yes or no. If he says no, then you should ask, do you want me to give you painkiller? He will say yes or no. If he says yes, then you have to ask 2 3 questions. Most important one is rule out contraindication. You need to ask, do you have any allergies to any medication? No. Do you have any problem with your kidneys? Yes, no. Then you can give the painkiller. Then you will say to the examiner that I would like to give my patient a painkiller. Then examiner will say that, assume doctor. If the examiner says that which painkiller, so you need to ask the patient score of the pain. If it's very severe, like 9 or 10, you will give the morphine. And if it's mild, definitely. Patient will say that, doctor, I can manage. So this is a thing about pain in the leg. And after that, you need to comfort the reassure the patient or comfort the patient. How you can do that? Along with confirming the identity, you will say that, are you John? Yes, yes, doctor. Okay, then you will reassure the patient by saying that, uh, John, I'm one of the doctor here, and don't worry, I'm here to see what's going on with you. For that, I need to check you from head to toe. So please bear with me, or please be with me. We'll see what's going on with you. The patient will say that, okay, doctor. After that, you will definitely go ahead with your A, B, C, D, E approach. Uh, Keep in mind one thing, that this is a Simman, and they have put Simman in the Plab too, because they want to see that how you would approach to the patient in emergency situations. If the patient is totally stable, you cannot find any abnormality in the parameters, it doesn't matter. Even you have to do the A, B, C, D, E approach to show the examiner that you know that in the real case scenario, I will do this approach instead of just directly going to the specific complaint of the patient. So you need to show examiner that you will definitely follow A, B, C, D, E approach in Simman. That's the point of keeping Simman in the exam. Okay, so if anyone has any question, he or she can raise the hand. So we have discussed this, like where will be the patient? Patient will be old age or middle age. He will be presenting with the severe pain in the leg. You need to, and yes, here one thing, most of the time definitely you will hear from other students that the pain is in the right leg. And definitely before going in, most of the time before going into the room, if you have prepared well, you will know the station most of the time. Although inside the room there will be some changes, minute changes, and GMC make that changes just to see that if you are scripted or not. So they will change a very small things. There will be subtle changes, so you need to go inside the room with open minded. And let me give you an example here. If you go into the room and patient said that, Simon said that, doctor, I have a pain in my leg, and you assume that it is a right leg because mostly it's in the right leg, the ALI in the right leg. Instead of asking which leg, you assume it that it's right leg, and definitely it will be a right leg, but the examiner will know that you already know the station, so you are scripted. So in Plab 2, never assume anything. If you know that the answer, if you already know the answer of the question, even then you have to ask that question just to show that you don't know anything about the scenario. You are not scripted. You will explore the things from the patient. Okay, after asking the which leg, definitely, as we discussed that either semen needs a painkiller or not. If needs a painkiller, you need to ask a few things, score, contraindication, and then you have to give the painkiller. And if the semen says that, doctor, I can manage, then you can move on forward. Okay, so let's talk about this specific station. When you go into the room, definitely you have to follow A, B, C, D, E approach. So patient is talking. So you can, when you go into the room, you can say that my patient is talking. It means that airway is patent. So you don't have to do anything in that. And if the patient is not talking or he is murmuring, means he is semi-conscious, even then never ever try to open the mouth by yourself. First always ask the patient, can you please open your mouth, and then look for any obstruction in the mouth. So in this station, either you can say that patient is talking, it means that my patient's airway is patent, or you can just say that, can you please open your mouth? And when he opens your mouth, just see if there is any swelling, if there is any bluish discoloration or not. If you find any swelling and bluish discoloration, definitely it will go into another direction. That is, we have a anaphylactic semen. So in this semen, definitely airway will be fine. And this is an approach which you can follow in all semens. After this, you will definitely go on to B, which is breathing. So for that, you can look into the monitor. Definitely in this station, oxygens will be normal, and if it's asthma or other stations, definitely oxygen saturation will be depending upon the station which you will have in the exam. So in this, oxygen will be normal, but you have to follow all the approaches. So just say to the seaman that, I'm quickly going to expose your chest for the purpose of examination, and for that, definitely I will have a chaperone with me for your privacy and safety. So can I proceed, or is it okay with you? You also have to get the consent from the patient as well. Definitely he'll say that, yes, doctor. Then, as Dr. Kura told you, that you will do inspection, palpation, percussion, and auscultation. There was a question, one of them raised the question that during this coronavirus time period, we cannot auscultate the chest. It's not the case. If it's relevant to the semen, then definitely there will be a stat, and you need to take on the stat and auscultate the chest. Um, in between the time, they do clean the stats, so that's their headache. But you have to do all the things. And the other question which someone of you asked in the previous class, that do we need to put the oxygen mask on the semen or just need to verbalize? You have to do everything. You need to put the correct mask from the table. There will be many things on the table, and you need to strap it around the face of the semen. Uh, Once you do that in a proper way, then oxygen will improve. Otherwise, it will stay down. And once you fitted the mask, you can just show the examiner that I'm putting this pot into the oxygen pot, which usually on the wall. But in the exam, it will not be in the wall. During the normal lives, there is oxygen pots in the wall. So that's the thing that you need to keep in your mind. And when you are doing for B, you need to check expansion and all those things, auscultation, percussion. At this point, depending on the semen, you can order ABGs and chest X-ray. But as we are talking about acute limb ischemia, so definitely you don't need to order X-rays or ABGs, because there will be no abnormality in that, and the oxygen saturation will be fine in this case scenario. Okay, so after that, you will move on to the third step, which is circulation. Here, you all know that you need to again see the monitor, and you need to check the pulses of the symbol. So in this case, when you are going for C, circulation, you will verbalize that my patient, I'll check my patient's blood pressure, which will be definitely on the meter, and then you will say that I'll check the pulses. You will check the radial pulse. At this point, you will also say that I would like to check the peripheral pulses as well. And when you will check the peripheral pulses, definitely you will not be able to appreciate the peripheral pulses in this station. So either it can be on the left leg or it can be on the right leg. Peripheral pulses, along with that, you need to check the capillary refill time. And in every Simman station on C, you can always order the ECG, and you can put the cannula and in every Simman you have to at least put one cannula. If it's not shock, Simman is in not in shock, then you have to put the cannula, at least one cannula in one arm, which is a wide bore large cannula. If it's a shock station, then you have to put two wide bore large cannulas. And when you will be putting on cannula, you need to take the sample for investigations, and we'll talk about later on what investigations do you need to take in this specific Simman station. Okay, so for peripheral pulses.
Hello, doctor. Doctor, please repeat the point where if it's not shock, and do you still need to put like two cannulas, or you can just put one cannula if it's not like shock and the blood pressure is either high or low,
Okay,
or like high?
right. Let me clear it again that if the blood pressure is normal, it means that Simman is not in a shockable state. So you can put one cannula in the arm, at least put one cannula in the arm, because you don't know after few minutes what if you have to give you have to give IV medication. What will you do then? Will you put cannula at that time? That will waste your time. So if the blood pressure is normal, verbalize that I would like to have one large bore cannula in my patient's arm. And if the blood pressure is low, pulse is very high, and you know that patient is semi-conscious, it's going into the shock, then verbalize that I want two wide bore large cannulas in my patient's arm. So that's the thing that I wanted to say, that if you think this is Simman, normal Simman, at least put one cannula in the arm. And if it's shock Simman, you have to put two cannulas in the arm. Okay, is it clear?
Yes, thank you.
Okay, okay, no worries. So
Doctor, also I
yeah.
want to ask you something. In acute limb ischemic case,
Mhm,
the oxygen saturation, we look to the monitor and oxygen saturation is, for example, normal, 95.
mhm,
We have
mhm,
to give oxygen
mhm,
because the patient is unwell, but
mhm.
do we have oxygen or not?
Yes, definitely. We have to give the oxygen. I will discuss that in a management part. So I will tell you the management part, but you have to. I'll in while at the end of this session, I will tell you what things you need to do side by side. I'm just right now. I'm just telling you what things you should not miss in this acute limb ischemia. I will address your oxygen part as well. Just remind me later in the end.
Okay,
Okay,
thank you.
so once you are checking peripheral pulses. At this point, you will know that it's acute limb ischemia. And let me tell you one thing: if you go into the room in the beginning of the station, because you most of the time you will know that from the outside it's a ALI, and you directly jump onto the peripheral pulses onto the leg, and you start taking history according to the leg, that when pain started, means Socrates, how uh, where is it radiating, not, or all those things, and you do not follow AB, then examiner will know that you already knew the station, so you are scripted. So to avoid that, what you will do once you go into the room, definitely patient will be shouting that I have a severe pain in my leg, and once you comfort the patient, he will let you do the ABCD approach, and he will let you take the history. How you can do that? You will ask the patient, or you will ask the Simman, John, okay, I know you are in pain. For that, you have to ask, do you need painkiller or not? After once you're done with that part, either he needed painkiller or not, you will say to which I mentioned earlier as well. You will comfort or reassure the patient by saying that, okay, John, I'm here. So I just quickly need to look you from head to toe to see what's going on with you or what's wrong with you, and then we can work on it together. So please bear with me. Once you say this, so Simman will let you do the things. And as Dr. Kurat said that while doing A, B, C, D, E, and your patient is stable, you can take the history side by side as well. Like once you are checking the pulses, at that point you'll find out that he is having a acute limb ischemia and there is absent pulses in the right limb. So you can start asking questions there. That first you will ask about the pain, that when did it start, how did it start, what were you doing when it started, uh, anything has changed the pain, is it getting worse or is it getting better, what is the score of the pain, have you taken anything for that. So all the secrets you need to ask. After the pain, uh, we will check other 6 P's for the acute limb ischemia as well. That is when you touch the when you will be checking the dorsalis pedis artery, so it will not be palpable. After that, keep in mind that you need to check the pulses of both limbs. Don't skip the left limb. You have to check the both pulses in the both limbs, both lower limbs. After that, mm-hmm, okay.
Dr.
Af-
Vakas, can I
mhm.
ask one question?
GG,
Actually,
yes,
I'm
sorry.
a bit confused. Like, you said that if the patient is even able to give the history, like in acute limb ischemia case, so still we,
Mhm.
after the patient has opened up for the initial symptoms, we have to say that is it okay that if we do the head to toe examination, then after that I
Mhm.
will be answering your concern. So,
Mhm.
do you think that we need to ask history before if the vitals are stable on the monitor?
Yes, definitely. You will ask the history, but you will say this word to comfort the patient, because then patient will know that he will be confused. Doctor, I have a
Mm-hmm.
pain in my leg. Why are you checking my chest? Why are you checking my
Mm-hmm.
mouth? Why are you checking my blood pressure? It's not of relevant. So
Okay.
once you say that, I will check you from head to toe to see what's going on with you. Then when you will be checking other parts of the body, he will be quite assured that you told me that you are trying to find out what's normal in there. And I'll tell you later on that in this station, either it can be acute limb ischemia solely, or it can be acute limb ischemia along with atrial fibrillation. So you will find out the AF when you will be checking the blood pressure. After that, you will be checking the pulse. When you feel his radial pulse, it will be irregular, and at that point when you will see the monitor,
Mm.
it will be very, the patient will be in tachycardia, and also it will be irregular. It will be 100 at one point, and at that point it will be 122 or 120. It will be fluctuating pulses. So that's why you need to tell the patient that I will be checking you from head to toe. And
So it's really good to go from head to toe in either case of in Siemens stations.
in
So
yes,
okay,
yes, of course, of course.
okay. Thank you so much.
No worries, no worries. So yes, we were there on the 6 P's point. When you check the peripheral pulses, it will be absent. After that, definitely you will check the posterior tibial, either it will be present or absent. Then you will move on upward. You will check the popliteal pulse. After that, you will check the femoral pulse. So you will stop where you will find the pulses, and you will verbalize that. And keep one point in your mind, that you have to talk to the patient, not to the examiner. You will not say that, examiner, my patient's dorsalis pedis is not palpable. You need to talk to the patient uh, during the whole time. You will say to the patient, John, I'm checking your pulses and I'm unable to appreciate it. I'm able to appreciate this one. I can feel your popliteal pulse. And at that point you will compare the temperature, or you can, because you are touching the patient, you can check the temperature right there and then. So you will compare the temperature of right leg to the left leg. It will be cold, it will be painful, it will be you will see the color, it will be paler, and there will be paresthesia, you can ask the patient, I'm touching you, can you feel my finger on this and on the other leg? So all these findings you need to tell to the patient that your leg is cold. I can see there is some discoloration. It's a little bit blue or paler, and I'm unable to appreciate your pulses, and it's cold. So this is the things that you need to do in ALI. Okay. After that, as Dr. Kurat have already told you that after C, then definitely there is D and E. In D, you have to do AVPU score. So patient is already talking to you. It means he is alert. He is in pain. So AVPU score, you don't have to do that. What is AVPU score? Some of you have confusion in this. It's a Simman, it's emergency situation, and you have less time in this scenario. So whenever there is acute situation, we do AVPU instead of GCS, because GCS is a long process, it takes more time. So they have developed AVPU score for emergencies. For alertness, if patient is talking to you, it means alert, you don't have to move on to next point. If he's not alert, you will call the patient name, either he will respond or not. If he is responding, it means voice, it's fine. And if he is not responding to his name or her name, then you will go for P. P is painful stimulus. You will put the pressure on supraorbital ridge and you'll see the facial expression if he is responding to the pain or not. So you will know that what is a conscious state of the patient. After that, if he is not giving you any response, it means the fourth one is U. It means patient is totally unconscious. So this is AVPU score, which we do in emergencies. And in D point, you can also check the glucose. So in hypoglycemia Simman, you will check the glucose at this point. Okay, from the start, you will know that if it's hypoglycemia or acute limb ischemia. If you know the station, just quickly go through the previous stages. Don't take too much time in A, B, C, because you know that you will find the finding in D. So try to quickly come to the point D. Just quickly check patient is airway patent, oxygen is fine, chest expansion, everything is fine, pulse, everything is fine. On D, I would like to check my patient's glucose. If it's hypoglycemia station, then definitely examiner will give you the finding 1.2 or 1.3, whatever the glucose is. So in ALI, definitely it will be normal. And once the finding is normal, either examiner will give you the reading of glucose or he will be kept quiet. So just you will say, I'll check my patient's glucose and then move on to next E. E is temperature. You already have checked the temperature in C because you were checking the pulses. You can check temperature over there, or you can check the temperature here as well. And I mentioned here is a chaperone and expose the patient. That chaperone, I would suggest you that you always mention this chaperone in the B or in the start when you are saying to the patient that I'll check from head to toe. So mention that I'll also have a chaperone with me right there and then. Okay. So while gathering the history, you need to keep in mind few things. Patient is in pain. You have given the painkiller or not, it depending on the situation. After that, you need to, first most important thing, you need to rule out the trauma. So while doing A, B, C, D, E, you will ask the patient, he will say, my pain is in my right leg. While doing the scrutinies, after that, you will ask the patient, by any chance, did you hurt yourself? He'll say yes or no. Is it happening for the first time? Yes, doctor, it's happening for the first time. Okay. So do you feel pain when you walk for some distance, or it's always there? So that question you are asking just to differentiate between acute limb ischemia or chronic limb ischemia. So if claudication is present, you will know that it's an old history. Or if he's giving you the recent or acute history, then it's ALI. Then you need to find out other causes as well. ALI either can be due to trauma, it can be due to thrombus, it can be due to atrial fibrillation. Definitely, after AFib, thrombus will be formed, it will dislodge and will block the arteries. You all know the physiology of that. So for that, other risk factors for ALI are smoking. You need to ask the patient if he is a smoker or not, because it's more common in smoking patient. And also you can ask the tea or coffee. High quantity of taking tea or coffee will lead to the AF, atrial fibrillation, and atrial fibrillation will lead to the acute limb ischemia. So you can, if you have a time, you can ask either you are drinking too much coffee or tea, or you are having too much stress in your life, yes or no. So it's, if you have time. If you don't have time, you can skip some of these points, but you should not skip any major points, important points, which I will tell you in a minute. So after that, definitely you are taking history, and once you will feel the pulse in C, definitely you will know that it's irregularly irregular. So you also need to ask the patient about chest pain, chest discomfort, or fluttering sensation in the chest. If he says that yes doctor, it's there, then you need to do the quick OD of there. Since when, how did it start, it's started for the first time, have you done anything for that? Just these 2-3 questions for that. Okay, so and 6P of the limb, I already have told you that. Okay, while you will be doing the C investigations, which you should not forget in this station, is that ECG. You will do the once you find, of course you will see the ECG in the monitor, but right there and then you have to verbalize that I will have a 12 lead ECG, because you will see the AFib in 12 lead ECG more clearly. So you'll say that I'll do the ECG. Echo, when you involve the senior, you will do the echo. You are taking the blood sample, so you will say I'll do the LFT, I'll do the kidney function test, and never forget about TFTs. I'll do the thyroid function test, because hyperthyroidism can lead to AF and then can lead to ALI. So TFT, ECG, and angiography, these 3 things you should not forget in this station. And then definitely you will do the angiography after involving the senior. So this is the investigation which you need to do here.
Doctor,
So,
what about the
yeah.
ultrasonography of the Doppler ultrasonography of the vessels?
Oh, vessels. Yes, you can do that as well.
Okay.
That's also will give you the findings of ALI. So after that, you will do the angiography, because angiography plus minus angioplasty, vascular surgeon will go for that. So ultrasound you can for both limbs or for both legs, you can do that as well. It's also done for DVT. In this ALI, you can do that as well. You can do that as well too. Okay. So those were the investigations, and no management. The oxygen point, which someone of you asked about oxygen point. So yeah, although in when you will be once you find out that it's ALI, and then you will give the patient oxygen, because you will not give the patient oxygen in B, because oxygen is already 95, and at that point it's pain in limb, although you know that it's ALI, but it could be something else. So if you give oxygen right there and then examiner might think that, oh, he already knows the sedation. You have to give the oxygen once you have established your diagnosis. So you will give the oxygen definitely to prevent the hypoxic injury, even if it's 95 or 96. Just give the 15-liter oxygen per minute. Wear non-rebreathable mask. So you will give the oxygen, and for that you can ask asthma as well, if you are asthmatic or not. If, because if it's the patient is asthmatic, then you have to give the oxygen via through Venturi mask at 24 or 28%. You will not give the oxygen via rebreather mask. So that's the difference between asthmatic or non-asthmatic. That's why you always need to ask the patient either he is having asthma or not. And for because in this patient either he will be having AF or plus minus AF, for that you again need to ask for if you are asthmatic or not, because if the patient is asthmatic, then you know that you cannot give the beta blocker for AF, then you have to give the calcium channel blocker or other drugs.
Yes.
So that's why. Mhm.
अभी बाबा का फ्रेंड पजामा नहीं था
Dr. Shazia, please mute your mic. Thank you.
Sorry.
It's okay. It's okay. Okay, so management, you have to give the oxygen and you have to give the painkiller either in the start, or if the Simman says that I can manage, then give in the end. And then you need to give the blood thinners. Once you find that it's ALI, you can skip D and E for the time being. Not for the whole station, but for the time being. On the C, once you develop that it's ALI, you can say there and then that I would like to involve my seniors because I'm suspecting it's acute limb ischemia, which is a critical condition. So I will involve my senior. I will ask a vascular surgeon to quickly come and review this patient. And along with that, if you haven't given a painkiller at that point, you will give the painkiller. You will say that I will give my patient painkiller, and also I'll give my patient IV blood thinner, which is heparin. So 500 5,000 international unit you have to give